First of all, thank you for having me. Wonderful city, and I'm just so grateful to be here. So just as Dennis showed that there was this huge impact of COVID-19 on the VA, I'm going to show you what we went through during COVID and what we've implemented since then and what we think is our new normal. So I'm from California, from the United States, and I'm just going to show you what we did, and I have no disclosures. So this is a robust agenda, and I know we're running a little bit short on time, so I'm going to go through it pretty quickly. Just so you know, KP or Kaiser Permanente is a compilation of multiple things, but I work for the medical group, which is then a capitated system within this larger organization. So we're affiliated with the hospital and the health plan, but we are a capitated medical group that's for profit. And I'm part of the Northern California system. Just so you're aware, we're 9,000 physicians, we are 140 dermatologists, and we have 4 million members, so our patients that we serve. And so just for a review of the process, we have had EMR, or electronic medical records, since 2005, and we've had patient-enabled photos to come in since 2010. We've been doing teledermatology since about 2010, and we do all sorts of teledermatology, as everyone is aware, whether it's clinician to clinician or patient to clinician, and even dermatologist to subspecialist. So I'm not going to go through this. We also do real-time as well as asynchronous teledermatology, store and forward, which everyone is familiar with, but also at the same time with the patient maybe in the office. So what happened? So as you can see here, since 2014, we've been tracking teledermatology and how much we perform in our organization. Since 2014, we started about 70,000 cases. And before COVID hit, our CEO was strategically trying to increase our impact in virtual care. Because we're capitated, we don't rely on fee-for-service as far as payment for every time we see a patient. So the more impact we can have in patients, the better it is for our organization to take care of all 4 million members. So we were already strategically increasing teledermatology. And then, as you can see, 2019, COVID-19 hit. In 2020, we saw this surge. The surge of teledermatology, or images we were reviewing, went over 300,000. Those annual cases of 300,000 stayed stable. And our hope was that as we come out of this pandemic, it would go down. However, as you can see, our annual projection for 2023 is remaining pretty high at 300,000 or 313,000. So what happened during that time? Image quality, where were all these cases coming from? As everybody knows, patients were not coming into the office. So because we had photo imaging from patients already enabled, the majority of our increase came from secure messages. Secure messages is our way of saying patients were emailing photos to their primary care. Those were either getting managed or being forwarded to the dermatologist. And as you can see, the volume was incredible. So more than 1/3 of our current volume is from patients. And photo quality also was going to suffer. But again, while we were strategically increasing the use of virtual care, we impacted a lot of different areas on how to educate around taking photos. And I think that saved us. Normally, when physicians take photo or clinicians in the office take photos, we have a poor quality rate of about 5%. But with secure message photos, we increase that to anywhere up to 20%. So we needed to enact more and more abilities to improve those photos, otherwise people were just doing the same work twice. So what's our new normal? What do we predict? And this is what we predict, is that before we had about a 2-to-1 ratio of in-person to telederm. We would see 400,000 visits in the office, and we would see about 150, maybe almost 200,000 telederm before COVID. Now, I think both the delay in care as well as the ease of teledermatology, we're now seeing about equal. Over 300,000 both in-office visits as well as telederm cases. So we could say we're taking care of more members. That's one way, the positive way to look at it. More of our members are getting dermatology care. But also, this is sort of a delayed effect as well of people who could not come in. And a couple of things that we're noticing is that, who are these people? Why are they coming in? And why didn't they come in before? And so just a couple of quick things as we do our research analysis of what's been going on before COVID-19 and what is now. One of the things we know is that before COVID, 99% of rashes that were simple, self-limited, were taking care of primary care. They never saw the dermatologist. And now we're not noticing that anymore. So as photos come in from patients, they're bypassing seeing their primary care physician. Those photos are now being sent to dermatology. And as you can imagine, if photos aren't as clear, we can't guide therapy. So we're noticing this transition of care that's simple and not necessarily high-value consultation to the dermatologist. The other thing we noticed is that some people just want to see the dermatologist. No matter what we do to try to give care earlier in their course, patients with acne, hair loss, pigmentation, they still want to see the dermatologist. Third thing we noticed is that synchronicity of care instead of asynchronous teledermatology. If you could be there at synchronous moment when that patient is seeing their primary care physician, and there's constant communication, whether it's to elaborate on the history or take a better photo when they're there, it gives better care. Patients are happier, don't necessarily go on to see the dermatologist. And then the last thing we notice is that there's no dermoscopy when patients are taking photos at home. So we already know that dermoscopy adds great value in stratifying benign lesions from malignant lesions. And we were able to stratify and see those patients quicker, do less biopsies, and the wait times improved. However, with the secure message photos and no dermoscopy yet, I'm sure it's to come. So without that, then we were seeing patients just for benign lesions. And we haven't done our analysis on biopsies now post, if we can say post-COVID, but we will be doing that. And it'd be really interesting to see how many more biopsies we're doing of benign lesions. So last couple of slides is really on what we've learned and some just practicality. The one thing I would say is always improve photo quality. Whatever you can do, whether it's internal. We have lots of guides for our clinicians, for our medical assistants, as well as for patients. We have pop-ups on our EMR where patients send photos to the patient portal. And as soon as you send the photo, we have a little guide on how to take photos. We constantly train our physicians internally as well as our staff who assist. And the second thing here is, I would say, is trust. Teledermatology has sort of a bad rap in the United States. It's not really seeing a dermatologist. And so we constantly try to improve our perspective that patients are having their images reviewed by a board-certified dermatologist who's giving real advice. So that's one thing, is image problem is going to exist for a while. And then increasing history. I mean, history is still essential for us. So we've developed questionnaires that patients can fill out. We've helped primary care take better histories that really just guides us on whether they need to come in to see us. And then outgoing. So that was incoming communication. Outgoing communication, we've tried to work together with our primary care departments on standardization. As you know, as Dennis mentioned, they're doing another job. Now they get this information from the teledermatologist, and they have to relay it to the patient. The patient, needs that in a friendly language, and so we have agreed that we will write that friendly language. So teledermatologists are all doing a standard response phrase, and it's easy to find the diagnosis and treatment plan. We use patient-friendly language. And also in the United States, chart notes are open to patients, so they can read every single record in their EMR. So we've tried, again, to be really cognizant of the fact that they should be easy to read, because sometimes they read the instructions before the primary care has even gotten back to them. So that's the improvement that we've tried to work together with primary care. And then patient information. This is a huge area. It continues to improve, but we've internally created handouts on common skin conditions. We have about 150 of our own. And then we always look for good reference websites and other types of companies that will do great patient handouts. So I really thank you for having me. And in the appendix, you will find all of the different things I mentioned. So again, things you can use to improve images. You can use these questions on important questions that primary care can use, patient questionnaire that we developed, and then our response to the primary care physician. But feel free to use any of the content. Thank you.